Can you hear me?
Hey, sorry, it had me rejoin. But if you did speak, I kind of heard you, but you did sound far away.
Okay, thank you.
Oh, you sound great now.
Oh, okay, perfect. Cool. Thank you. All right, just waiting for Jason. Hey, Jason. I'm gonna go ahead and make you a co-host. Yes. I don't know why it.
Hello.
Hi, how are you?
Good, how you doing?
Good.
Okay. Second to last one. I'm gonna start getting emotional.
I know. I know. My Mondays won't be the same.
A little earlier, hopefully for you.
All right, so I made you a co-host. You should be able to do all the things
Okay. Yeah, if you want me to just do my thing like
whenever you're
we've done.
ready.
Okay. I'll do that then. Perfect.
Thanks.
No problem. See a couple of people coming, and we'll get started like we usually do, about a minute or two past the hour. Thank you for being here. get started in just a minute. Okay, I'm going to get started. There's a lot to cover, and I know these are being recorded, which is really great because I know this could be a difficult time of day for some folks. So thank you for being here. This is our second to last of the training series. Really excited to talk to you about this topic tonight, which is dual diagnosis. So people that have both a developmental disability, and in addition to that, they also have a mental health diagnosis. As you can imagine, there are a lot of complicated nuances of how to treat somebody with different types of psychiatric disorders. My experiences will, give a psychiatric as opposed to a psychological interpretation and foot forward about this, only because the majority of the environments I've been working with folks was in hospitals, healthcare settings, things of that nature, crisis settings. So, take that with a grain of salt when I start talking about specific diagnoses. At the end of the day, I'm sure it's the same requirement it is on in New Jersey that you're supposed to at some point, I believe, take psychological first aid. That all still applies to folks. You try what you can, what you've learned from me, from the reading that might be out there for folks that have a developmental disability. But at the end of the day, it's those basic tenets of how to talk to human beings, and just remembering that they should be treated as such. And I say that to open up kind of where we're going tonight. And this is going to feel probably less formal than it has in the past. I know sometimes it feels a little college lecture-y, and I apologize. Tonight's going to be more about like what I've seen and where things will go. But as always, there's a little bit of a context to it. And I'm also aware that you may have seen or heard some of this stuff before, just because there's a lot of overarching things here. But the one thing that kind of kicks off where this all begins, so to speak, is what was known as the Olmstead Act. So in 1999, the Olmstead Act was passed, which essentially started the deinstitutionalization of some of those really large federal and state they look like mental health facilities or hospitals. But we're talking like Pennhurst, all those really old buildings that probably remind you of movies and things like that talk about psychiatry, like One Flew Over the Cuckoo's Nest, these very, very large, essentially campuses where people with a developmental disability, for the most part, would be, I don't want to use the word forced. Some were absolutely forced to be there. And this resolves itself again. This is 1999. I'm not that old. At least I don't think I am. My kids think I'm old, but realistically, 99, that's not that long ago. It's 2025, so 26 years, maybe, or a couple of years to build up the legislation. This is still going on because there were so many people in those institutions. And what happened was it created some of the things you might actually be hearing about in the news right now because of, again, always saying as unbiased as possible, there's a lot of talk in the news about Medicaid and how Medicaid is going to be funded over the next couple of years. And you might hear something when it comes to talking about people with developmental disabilities or intellectual disabilities that their funding is, I am not saying this, there are people that are fearful that that is what's going to happen, that services are going to be removed, and that people will be floundering in the community and not have services. The whole purpose, and reaching back all these years, the purpose of the actual Olmstead Act was to make sure that that doesn't happen. So Olmstead, in addition to closing the doors on a lot of these institutions, it also created something called home and community-based services. You might see the HCBS in places when it comes to Medicaid or Medicare services. And what that means was the legislation made it law that people that were coming out of these institutions, or in general, needed to be given enough services in the community that they could meet the criteria to live in an institution, but could still be have a fruitful life in the community itself. So that's where we get a lot of the group homes that you've heard me talk about. If you live or work in any of those settings, you know that that's where it comes from. And what happened with that, if you remember one of my talks from a couple of weeks ago, when I talked about we have this great thing that happened. We are getting people to live longer now. We're getting people that used to live till their early 40s are now moving into their upper 60s, hopefully a little bit longer than that. But if you remember, there was a two-sided sword to that, because now we have people that are living with chronic, very debilitating issues for 20, 25 plus years because of that rapid aging. So sometimes we identify an issue and we deal with that issue, and then another one pops up. It's like the old stick your finger in the dam to stop the leak and two more pop out. So that's kind of what happened. There was this back and forth of what's the level of person that can come into the community, who should stay in. And really, a lot of these places have all closed. There are a few left that do exist. There are some people that do live in institutional settings, but the vast majority had done phenomenal and did really well. It eliminated this old issue of quote unquote warehousing people. It wasn't that hard to drop a relative off and say, okay, this is where you're going to be now. I mean, you're talking about absolute, by today's standards, human rights violations up and down. And this isn't, I'm not even talking about people with mental health issues, just people with developmental disabilities. Not that that should signify anything beyond that, but based on society pre-1999, you can imagine the stigma was quite profound. So we did create this new issue, but it was much better for the population. I just got back from a national conference. The American Association on Intellectual and Developmental Disabilities was just last week in DC. I was there. I actually presented about what we're doing here in an effort to try to get more people and more units to do that outside of Philadelphia. And we'll talk more about that when we're kind of wrapping things up next week, or whenever that is. I think it's next week. But even to this day, you're still hearing about people that are either still institutionalized or some people that want to go back, which might make you scratch your head quite a bit. And I heard, phenomenon of people referring to it almost like if somebody is spent a long time in an institution or a jail, sometimes they feel less comfortable in the community that they originally came from and want to go back into that world because it's so secure, it's predictable. Maybe some cases it's predictably unpredictable, but I had a client who she had some mental health issues, but it was really driven by developmental disabilities, and her urge, or not, I shouldn't say urge, her true wish was to go back to one of these places. And she told me to my face, I am going to keep hurting the group home manager until I go back. And she continued to do that. And she couldn't go back. There wasn't a space for her anymore. And eventually it got dealt with, but it was this wasn't great for everybody. It was a huge change in somebody's life, a huge change for Medicaid, a huge change for the families and the caregivers and the social structure that goes around here, because now we have a lot more people in the community that we didn't used to have, and people are going to take notice, and people aren't always that accepting of big changes in the world. I am apparently drawing now. Okay, there we go. You may have even seen this. I'm not going to spend a lot of time on it. Long story short, you've probably heard me say this multiple times. Keep in mind, back to 1999, we did not have, historically speaking, these universities, these medical schools, these nursing schools set up to require as many specialists that the community needs, because these folks weren't in the community. They weren't being planned for. They weren't being counted. So when you've got people doing population health at a very high level, trying to figure out, do we have enough doctors for the next 10 years? Do we have enough dentists? All those things. Well, guess what? The planning wasn't really that great. Still isn't. So that lack of education for the people that first came out, they ran right into a wall and were really hurting for services at first. We're still doing our best to get services together. There's still waiting lists for basic things, forget psychiatry involvement or any specialty need. But there are still a lot of issues with that. Only in the last 15 years or so, 16 years or so, the American Academy of Developmental Medicine and Dentistry started these large funds for IDD education. It says the word large. I don't know that all numbers are created equal. You know, sometimes a $2 million grant sounds like a lot of money, but that's enough for like 3 people to maybe go through medical school and then to become specialists. It's really not that much. So we need a lot more money and funding behind all of that. And we're running into an issue. Your public health folks can tell you with doctor shortage. If you haven't experienced that on your own yet, you probably will. Waiting lists for things are getting longer and longer because there is that lack of specialty. Before I dive right into the heavier stuff for tonight, I wanted to just make you aware of crisis response centers that you have. These are open 24 hours a day, 7 days a week. This is where I didn't work in one of these, but I worked in a New Jersey equivalent of these. I just wanted you to see it physically on a map. I literally just pulled it from their webpage just so that you can see it. And when I get all of these to you, this will be in there just so that you know that they're there. You know, I don't know your geography, like obviously Sonia and Satori do. The geography of your city, where people may or may not be coming from. It's just good to know that these things are there and these things are open unless the hospitals themselves are closed. These are typically emergency room departments, or they are locked units right off of the emergency room department. But it's important for you to know that, because if things are going sideways in a situation in a shelter or anywhere really, it's important for this information to be available. 988 gets you linked to the closest person for this. So I believe that's the easiest way you'd be able to do it. I just wanted to give you something concrete so that you have it, so that it's here, it's recorded, it's there, because your events, your shelters could be anywhere among these different places. So it's important to know, because sometimes you can't send somebody in a car. You can't just take somebody. Things get a little bit interesting when you get down to the logistics of dealing with a psychiatric crisis when the person doesn't want to physically go. So again, just keeping that in mind. And of course, children is a really important one, because again, you're going to hear a lot of stories about adults, but children have the same or similar issues. Even the young ones can still have some of these rare psychiatric issues. And when you throw a person again into that mix of, if you've been deployed, something is not going well in the world around everybody. So people with these psychiatric issues, mental health needs, and just developmental needs in general are going to need that presence and confidence and the feeling of being in a safe environment. And that can be challenging to do in a safe environment that's routine for a person, let alone a strange new environment. So having said that, I'm just going to give you a little bit of background. I know I did this weeks ago at the very beginning of this, but just a quick synopsis of what I did and why you're hearing these stories. Specifically so that you don't think this is what walks through the door every day. It is not. I used to work, like I said, in one of those crisis centers in New Jersey. What happens in New Jersey is it's a little different. Somebody like me, who has graduate degrees in psychology, is certified by the state of New Jersey. You guys have something similar, but essentially, I am one of 2 decision makers at that time while I'm seeing somebody to evaluate if they need to be involuntarily committed against their will, which obviously takes away somebody's civil rights temporarily. It involves a judge's order and a psychiatrist in addition to that. So the way that the law in New Jersey is, it's very specific, which is why I'm leaving the Pennsylvania side out of it. Again, this is just so you understand the person that's telling you the stories that we're going to get into tonight and next week, because there's obviously some crossover there. So again, we were open 24 hours a day. In the situations where a person having a psychiatric crisis was physically already brought to the hospital, we would see them in the emergency room, see them in our secure area, and sometimes we would see them on a medical unit, depending on what the issue was. And we would have someone sometimes with severe postpartum depression, for example, after delivery of a baby. Sometimes we would have to go up there and talk to somebody. Sometimes we would be going to geriatric floor because we weren't sure if somebody was having an issue with dementia or they're having a psychiatric crisis. So we would go everywhere and see everything, which is why the medical stuff with the developmental disabilities feels a little, on the natural side for me, because a lot of it is mixed in there. In addition to that, if a person who was suspected of needing an evaluation because they might be a danger to themselves, others, or property because of a mental health issue. Notice I'm saying mental health issue. I'm not saying developmental disability. They are two completely different things in the world of the law and in reality. A lot of times people, and we'll get to that in a second. I'm getting ahead of myself. But due to a mental health issue, a psychiatric issue, is why this person's acting this way. We would go into the community, which means anywhere where this person was. It could be their house, their living room, their backyard, their apartment. I saw somebody who was living in a storage unit. So somebody in a public library, anywhere that you can imagine, or you've ever seen somebody having what looked like a psychiatric issue, I was there. So what would happen at those times was I would go with the police, kind of like how you hear people are starting to do it now over the last couple of years. But this is going back a ways. This is kind of a unique thing for it at the time. And we would go with the police. The police can't just take somebody because they haven't broken a law. So they would wait for us to do a quick evaluation in the field and make a determination whether that person needed to be taken to the hospital, frankly, against their will. And again, there's a balance of civil rights versus ensuring safety. But nonetheless, that's kind of all of that's out there. And I'm going to go into more than just these next week when we go over just mental health in general. And I'm going to talk on some other things, but I wanted to really give you some light background on the psychiatric diagnoses and then go into some case studies that I have put together for a couple of other trainings that I thought would be good for you all. So here I have listed the big couple of categorical diagnoses. And I mean by that is they are not necessarily taken as their own category, but some of them have something to do with the one that they're next to. But in any case, these are the disorders that you would see more prevalent among the population with developmental disabilities. And again, this is probably a review. You probably actually have seen this slide before, but I wanted to just show you, again, the prevalence of how common these things are. And just to kind of beat it in your heads one more time, you definitely have seen this before. But on the right side here, we have the percentage of the general population with the disorder. And then on the left side and middle are people with Down syndrome and IDD, or somebody with just any type of IDD, so it's some form of a developmental disability. And you could just see for yourselves, the numbers are significantly higher for those that have either Down syndrome or IDD when compared to the United States general population. And again, that doesn't mean every person you run into is going to have a disorder, but nonetheless, it certainly shouldn't be that they can't have a disorder, which is something that I've heard people say before in the past. And, we'll talk about some of that this evening as well. So one of the first disorders I wanted to talk to you about is bipolar disorder, because this is a really tough disorder to deal with sometimes because, well, let me just explain to you what it is, and then we'll go from there. So and these are paraphrased, these definitions are paraphrases from the actual APA diagnoses. So you have a period of time that's at least a week, of this irritability or changing mood where, day to day, humans feel a web and flow, waxing and waning of our emotions. Somebody with bipolar disorder has really, really highs and really, really lows, really, really low lows. And these ups and downs can last for weeks or even longer at times. The one thing that doesn't happen, a lot of people get confused at times, is thinking bipolar disorder, somebody has this when they are really, really happy and then they can get really irritable the next moment and back and forth. That's not bipolar disorder. That's probably a symptom of something else. But it certainly isn't the criteria for bipolar disorder, because it's, in addition to this fluctuating, very noticeable mood change, is having several of these other listed symptoms here, having grandiosity, believing that you are more important than you are. And I don't mean like you think you're due for a promotion, but your boss isn't nice to you. I mean, you believe you should be running the company when you just started there, or you believe that you might be, we can get into delusions where we believe we're somebody that we're not. Like, I've had plenty of people believe that they are some type of religious figure, something of that need. Another issue is that this decreased need for sleep, which again is part of the reason why bipolar disorder can be very tricky for treatment, because there is a time where some people don't want to take medicine because it's going to make them actually come down from where they're feeling. And I don't mean like talking about drug use or recreational. I just mean the regular prescribed medication. There are times where patients don't want to take that because it's supposed to level folks out. And sometimes somebody that's feeling really, really good doesn't want to come down from that. And that's kind of an understandable thing. Throw on another layer of somebody with a developmental disability who may not understand the reasoning behind why they're taking a medication. And you might think to yourself, you know what, maybe that's okay. Sometimes people just take medicine because they're told to by an authority figure, whether that's a caregiver, a parent, a roommate, a spouse, whatever it is. Sometimes people just listen. But there are a group of people that have a developmental disability that can understand and should understand why they're taking their medicine and what it's for. And that can start to become problematic in these situations because, again, they still feel what the rest of us feel when we get these labels of diagnoses. You might see somebody that's more talkative than usual, flight of ideas, or they just, not only can they not shut up, but they're going from one thing to the next to the next. They're very distracted. And really just can't manage to stay on track. Excessive involvement in activities that have a high potential for painful consequences. I was seeing somebody once, I'm going to save some of my other stories for next week, but I was seeing somebody once who had no sailing background, had never been on a boat, or neither am I. I didn't know what was behind any of this stuff either. I'm not that kind of person. But this person who showed up in our emergency room one night, again, I'm in Jersey. This person was a resident of somewhere in the northeast region of New England, and had actually bought and sailed a sailboat from there at midnight on a whim and crashed off of our shores. And when I spoke to the person, they thought it was the greatest day of their life. They were having a good old time, could not see any consequences here. This person had taken out a second mortgage to be able to afford the boat in the first place, then destroyed it. I don't think insurance was involved. Again, this isn't a well thought out thing. This is impulse. This is lack of impulse in an adult, and can be a child. Sometimes we see gambling. Sometimes we see drug use. Sometimes we see all of it. But the minimum is at least 3 of these things, right? Because you can have a decreased need for sleep and be more talkative because you are getting that promotion and you're excited about life, right? So you have to look at these things through the lens of what that actual criteria is. And I'll get into more of the bipolar disorder next week, because we'll talk about things pertaining to psychosis and what that looks like and how you can try to see it. There we go. Major depressive disorder. This is a real tough one for the IDD population because, again, there is this niche this niche group, I'll say, of people with an intellectual disability who are very aware that they have a developmental disability. They're aware that they are not necessarily going to have the same accolades in life. I had a client say to me once that he was feeling really down, and he had just kind of come to the idea that he's never going to get married. He's never going to hold a job for more than a few months. Never going to drive a car. All of these things were being fueled by an undertone of him having a major depressive disorder. But a lot of what he was saying was hard to argue with and be like, oh no, you still got that, those types of things, because not everything he was saying was totally wrong, but some of the things, he was accurate about in his level of insight about his own needs. And that is where counseling and things like that do come in handy for people with, developmental and intellectual disabilities, because you can receive that. You can understand to a degree And my own personal experiences in the profession always found that group of folks to be the hardest to assist and support, because that insight and that very arduous and just cold pessimism about their life, it's really tough to swallow. It really is. I remember I was sitting in a group home kitchen table with him, and he's like, look, I can't even get privacy here. He's got, people all over the place. And, sometimes situations cause the depression. Like I said, he was borderline intellectual functioning and was living in a home with much older people who had much higher level needs, and he had nothing in common with them. And the group home workers are their workers. So he was feeling very isolated. And that's where major depressive disorder can really become problematic for somebody with IDD. And it says here delusional guilt, sense of worthlessness. So feeling like he wasn't contributing and being a drain on things is tough to hear from somebody. And this delusional guilt, thinking that it's their fault, that things that have nothing to do with them are occurring. I remember he said to me that he was sorry he was telling me all that, because he knows that that was also a way of him telling me that I, as his therapist, was failing him, which really hurt to hear. Not because of the failing him, it was that he cared enough to care about me. So you got this guy who's essentially socially living by himself, even though there's people around him, very depressed, all of that, recurring thoughts about death. And he ended up going to the hospital. I didn't feel good about him leaving, because everything was so concentrated around failure and pessimism and just nothing working out. And there's a word that comes to mind. It's a fancy word. It's called anhedonia. And anhedonia is, if you pick it apart, it's the removal of anything hedonistic, anything pleasurable. So anhedonia is when somebody has no pleasure in life. And you might hear somebody say that, but when I talk about that, that means, the people that you might try to help at a shelter and might ask them, like, what's your favorite food? Maybe we could somehow get a pizza here. Sometimes Chick-fil-A drops stuff off. Yeah, you never know what you could get somebody to even look forward to while you're there as a volunteer working a shelter. Hey, when we get out of this, if you're able to really help us out today, maybe we'll all go out for something tomorrow. Like, just trying to keep things out there. That is tough with folks that are on that borderline, because they are really in tune to the pessimism and being around disaster and all this other stuff. It's just another issue that's not working well, and it can be very, very difficult. So you being there for that person, again, using that psychological first aid, using that empathic approach, is really helpful, and it'll go a lot farther than I think you realize it will. And it'll also teach that person that there are people out there that are safe, and there are places that you can go that are also safe. Right. We'll come back again to all of these diagnoses when we get there next week. Okay. So generalized anxiety disorder is kind of a pickle. So there are almost an equal amount of the population that have generalized anxiety disorder, about like one out of every 5 people. And it's this just undertone of worry and feeling not centered, just feeling off, feeling fatigued or restless. It's not a panic attack in that you feel like the sky is falling and you're literally potentially about to die, but I don't want to use the word mild. It's more of a chronic, all the time, can't get away from it, sustained feeling. And, it's worrying, and obviously the word anxious itself. And then these 3 symptoms. This restlessness, feeling fatigue, difficulty concentrating is another one. If you notice somebody who, and I'm going to come back to this about the concentrating thing, or the mind just going blank, muscle tension. Sometimes people are so unconsciously good at repressing or just making their emotions go away that they start to physically have emotions. It's just one of those things. Your body's going to react to something no matter what you try to do. And then sleep disturbance. Are we sleeping too much, or are we not sleeping at all? Are we having racing thoughts at nighttime? When you go to bed at night, even in your own life, are there times where you just can't shut it off? Are there times, and this, you'll run into this at a shelter if you're doing an overnight. People that aren't able to sleep, it can be due to other issues, but anxiety is definitely something that's present, especially in a shelter environment where people are not only worrying about the environment that they're physically in, but they're worried about wherever they just came from and the people that are in their lives, of course, as well. So anxiety is definitely going to be prevalent in one of those situations, especially with somebody with developmental disabilities. But with developmental disabilities, they're not going to look, their symptoms won't come out the same as they will for somebody that doesn't. You might just tune into social isolation, a change in behavior. It might be their caregiver that tells you they're just acting differently because you don't know them at that point. But you'll see even body language. I'll come back to body language with a bit more when we finish up next week. But looking at somebody, are they biting their nails? Are they constantly playing with their hands? Are they sitting there with their arms crossed like this? You can learn a lot from somebody by observing them, especially somebody that may have IDD, may not use words to communicate. So there's a lot that can go on there. The other thing that really becomes an issue with folks with IDD is caffeine intake, because sometimes we like sweets, sometimes we like coffee, sometimes we like soda, and caffeine is in all of those things. And we don't always remember or associate the caffeine intake with what we're drinking. And I'll tell you a story about a guy I was seeing who seemed to be doing fine. He had some anxiety here and there, but his issue was he could not go to bed at night. And he would swear up and down that there was nothing on his mind. He just wanted to keep playing a video game, keep doing this, keep doing that. Nothing that made me think there was any worry. And eventually it came out through conversation with his group home manager that he was drinking a 2-liter bottle of Coca-Cola every day when he got home from group home. So he was first ingesting hundreds and hundreds of milligrams of caffeine at like 4 o'clock in the afternoon. So that was figured out, not to mention the volume of liquid also was keeping him up. So sometimes it's something very small, sometimes it's not. But again, it's all about trying to iron out those things and figuring those things out. Post-traumatic stress disorder is something I would absolutely be on the lookout when you're working in the IDD population, because the rate and the prevalence of victimization of people that have developmental and intellectual disabilities is disproportionately higher than the general population. So post-traumatic stress disorder in and of itself symptomatically might be around. You may not see a diagnosis because it can take a really long time to tease out everything else and figure out that there's a PTSD thing going on. But nonetheless, a lot of times it's there. And that's, again, happening because there were opportunities that were taken advantage of a person. And again, back to where you physically are while you're interacting with these folks could be reminding them of things, right? Your shelters might be in a school setting, could be in any building, realistically, any government building. Somebody with IDD or in the general population can hear something, see something, smell something that reminds them of the traumatic event that happened in the first place. And so you have to be on the lookout for things that might be triggering to people, which is a very difficult task because you don't know what it is unless you know the person. So sometimes the caregivers are people that you might want to just like get a rundown on the person. Is there anything that we need to know that you think might be helpful in situations overall? But PTSD itself is witnessing a traumatic event, either witnessing it or you are the one experiencing it yourself. Learning that event occurred, sometimes helps, doesn't help. It allows you to meet the criteria in situations, let's say, of sexual abuse. Two siblings grow up and they're in their 30s when one sibling tells the other that they had been sexually abused their entire childhood and the other one never knew anything about it, and it's the same parent. That in and of itself can be a traumatic event for that person, just because they'll start feeling guilt or attach any human emotion to that process. So that can be an issue. Experiencing repeated or extreme exposure to bad details of an event. So this wording actually comes from a change that happened after 9/11. After 9/11, if anybody remembers, the coverage was very graphic. It's 2001. There's a lot more video cameras around now. It's almost like when the Vietnam War was being broadcast on television for the first time. There was a big change in how we looked at, veterans, maybe in hindsight after the fact. But it was similar for this. And so what happened was, like, people watching it happen live. Like, I was there, or not there, I was watching it happen on live television after the first plane hit. And then as we're sitting there watching it, like, we were watching it because we heard about that. And then the second plane hit as we're watching. And then we saw the falling and then the fall and then everything else that went on. So that in and of itself has now, the criteria was changed because so many Americans witnessed something in such detail. And that might be something you didn't know of or thought of, or but it's something that is out there. So because our social streams, our media is so much more detailed, even just the high definition of things, if you watch television, is so much more graphic than it was only a few years back. So somebody that might be having these symptoms might have these reoccurring flashbacks. They might have these intense psychological episodes where they are acting it back out again because of a cue that happened, that stimulated them, that triggered them. Physiological reactions to things. I had a guy who had come in once, and he was a veteran of Desert Storm, of the war in the 90s from Iraq. And I remember him telling me he was in talking to me because he was having panic attack after panic attack after panic attack. And you can have panic attacks on top of PTSD, on top of generalized anxiety disorder. You could be born with generalized anxiety disorder and develop all the rest of it. And he was essentially dealing with all that. And I remember him telling me, sparing you the details of what happened in Iraq, but he witnessed somebody right next to him be killed. He was telling me he was tasting it. And this is something that had happened 15 years before he was sitting there in front of me. And as it was happening and he was talking to me, he was telling me how he could actually taste some of what was out there. And then to just bring it down a little bit, my wife and I were in a car accident a number of years ago. And if you've ever been in an accident where the airbags deploy, there's a smell. If you've never been in a car that happens, you don't know what I'm talking about. But if you have been, you know what I'm talking about. If there's like a sulfur smell to it or something, and if you ever smell that again, it brings my wife right back to the accident, which is unfortunate. But that is a direct neurological side effect of your brain being rewired for that traumatic event. And it was rewired to get you through it, and now you're still dealing with it all those years later. Again, back to the IDD brain, the neurological network may not be as efficient as it is in the general population. So you can imagine, again, when there might be some misfiring, or there might be some chemical imbalance for whatever reason, or there's an outside external trigger. Again, those things can be really exacerbated quite a bit. Schizophrenia, I am going to get really into detail next week because I know it's typically the one that most people want to hear a lot about. I'll just go over it briefly so that I can get to some of these case studies. We're not going to get to all of them, but we will get to some, and then we'll finish the rest of them next week as well. So schizophrenia and other psychotic disorders are all in one big category now in the Diagnostic and Statistical Manual of Mental Disorders. Now we're on our 5th version. We'll have a 6th probably in the next couple of years, that all of this can get changed. But at the basics of it, you're going to have 2 or more of the top menu there. So delusions, to just give you a basic definition, delusion is when you are having a disturbance of your thought process. So you think you are Jesus, you think you are God, you think people are after you, you think your food is being poisoned, things like that. There are a lot of subtypes of these delusions. There's delusions of persecution, like somebody's being chased or someone's trying to hurt you. There are delusions of grandeur, like I mentioned, and really a lot of times, unfortunately, most of the time, I'll say the delusions are usually very magnified and very harmful to the person's social interaction. And I'll give you a good story next week about the Queen of England, who was not the Queen of England, but this person thought they were, and it turned into a very interesting story. But nonetheless, the person got what they needed, and we will come back to that. The hallucination side of it, there are 5 senses, right? Typically speaking, somebody with a psychotic disorder or hallucination is going to have one of 2 types. They're going to have auditory or they're going to have visual. They can have both. You can hear things and see things at the same time. I will tell you that 99% of every psychotic person I've ever met does not, like, when you see movies or you hear things, the most entertaining things are what's in front of you because people are trying to sell you movies and stories. The reality is you're not seeing the devil standing right in front of you. They're not seeing me as real as I look to you sitting next to them. Most of the time it's described as dark, shadowy figures in somebody's peripheral vision, where you might notice them looking and looking because they're constantly looking around because they think they're seeing something that isn't really there. The process of the person turning their head to look around is something that is important for you in the life of a volunteer in the MRC. If you see someone, might be something where you might start seeing somebody talking to themselves, or in what I'm talking about, somebody like moving around, looking around the room. That is, the phrase is called responding to internal stimuli. That means that this person is perceiving something through their eyes, their ears, or their brain's thoughts. Now, I will tell you, and this kind of is a segue, and we'll come back to schizophrenia, like I said, into something called diagnostic overshadowing. A lot of times we assume that somebody is psychotic because they are having hallucinations, specifically auditory and or visual. But there's also a few other things out there. Number one, there's something called command hallucinations, which is the worst type of hallucination that you can have because they don't say nice things usually, and they're usually telling you to do bad things. So a command hallucination is a patient in front of me telling me there is a voice in my head right now as I'm talking to you telling me to kill myself or telling me to kill you or everybody. I've been saying this for years since I've been talking on this subject. I've never heard anybody get an auditory hallucination that was pleasant. It just doesn't happen. The other thing I think it's very important for everybody to hear is we have other senses, right? We have taste, we have touch, and we have smell. Almost forgot them. If you have somebody, with the exception of the PTSD guy that I was just talking about, who said he tasted something, he wasn't really actually tasting something. He was kind of re-experiencing it. And it was very clear he wasn't psychotic because he was looking at me, having a conversation with me, all those things. He wasn't responding to internal stimuli. He wasn't looking around the room. He didn't have disorganized speech. Grossly disorganized means somebody's wearing, a suit jacket and sweatpants, and like they just don't look like they know how to get dressed. That might be when you see somebody dressed for the winter and it's 95 degrees out. Again, that's gross disorganization. But you might also see negative symptoms, and that doesn't mean bad. Negative symptoms means something that's not there that should be. So if you're talking to somebody and they have a flat affect, meaning that their face shows no expression at all, or they're sad for no reason, they just start crying or they start laughing. Those are things that aren't supposed to be there, that are there. And so that's a negative. But positive symptoms are things that are there that shouldn't be, like delusions and hallucinations. But the other three senses, to come back to that for a sec, are really important because they're almost always going to be a medical issue. Smell, taste, and touch are very likely to be that because it could be a brain tumor, it could be a stroke, it could be a medical emergency, or it could be something inert. But nonetheless, it's very, very unlikely that it's going to be something psychiatric. So when we talk about that, where we think one thing isn't the other, it's called diagnostic overshadowing. I'm throwing this up here for you to see. This is a mental status exam. Again, something I'm going to come back to and talk about more in detail next week to kind of drive it home. But this is something that you could use mentally, like in your own brain, or even have it there. This isn't like a clinical document. It's not an actual healthcare diagnostic tool until you're actually using it with somebody's name and their date of birth and all of that. But if you are suspicious of somebody that's there, this is a good reference tool to use, just because you could put all of those symptoms that somebody like me is supposed to be able to figure out when they're talking to you. You have a black and white sheet here that can tell you if there's too many red flags on something. You guys work in a city, you live in a city, you're going to have people with all sorts of different emotions and how they dress and all of that stuff. Like, I'm from Jersey, but I'm a New York guy, so I get it. People come as you are. But when you start seeing their inappropriate appearance with speech that's all over the place, and their mood is euthymic, it's the best day ever, they're so happy to be here in a shelter with you, right? That mood doesn't match the environment. Then your brain should start thinking, okay, there might be something going on here that we might just want to keep an eye on or offer them assistance. Just because they're having symptoms of a mental health issue, again, I have the extreme bias of the people with the most acute conditions. That is not the 99.9%. So again, people are approachable. People do want help. Just that approach, being comfortable. This isn't your job to figure out, but it might be helpful for you to say to somebody in charge, like, I learned about this, and this is kind of something we talked about. And then there's obvious things, right? If somebody's telling you they're suicidal or homicidal, that's something you should be addressing immediately. So again, it's just something that sometimes people like to have for their own, volition. I'm skipping through a couple things here because we can come back to them. But diagnostic overshadowing is one of the stories I probably told you about, how we thought somebody was having a psychiatric emergency, and in reality, the person had a blood sugar of over 400. That is stigma getting in the way. But for you guys, going back to some of the things that you've learned to make sure that you can make sure that you have a good sense of what should and shouldn't be in front of you. And then you have some tools to work through some of that. But diagnostic overshadowing is an example of getting it wrong, unfortunately. And I'm going to skip ahead on this one because we've actually talked about this guy before. So I'm going to go right into this guy. This is somebody I wanted to talk about. Actually, let's come back to this guy. This was someone I had talked about before who was had Down syndrome and was repeatedly telling people that he was suicidal. And over some time, he had visited us several times. And if I've talked about this before, it's okay because I want you to see what it actually looks like when it's completed. With this being a mental status exam, the way it was when I saw this person at the hospital, this is what you'd see. somebody's pulse, their blood oxygen, and their blood pressure, all of which should have been done before they saw somebody like myself. This person is telling us, I'm at the hospital, I'm scared, and I'm gonna hurt myself. Their known diagnosis is Down syndrome, reported by their group home staff with no inpatient history, with lots of crisis visits. Their speech is normal, they look fine, but they're avoiding eye contact. Not a huge deal, but maybe there's some anxiety, maybe there's some low self-esteem. Their affect is flat. So that's something else, right? That's a symptom of something that should be there that's not. And this person is flat out telling me they're scared of killing themselves. We had some short-term memory impairment, right? If you remember back a couple of slides, memory, forgetfulness, not being able to think of the words is another symptom of depression. So you can see how we're kind of putting these things together, even the person's motor activity. So I'm observing this person as they're physically walking into our unit, and I'm noticing that they're slower than normal. This is a 25-year-old with Down syndrome. Guy was in good shape, if I remember correctly. Like there wasn't obesity or anything like that. Guy was pretty athletic, if I remember correctly, and it was just everything was very slow. Even to drink the water, it was like exaggerated, slow response. And to the point where you think, like, is somebody messing with me? Like, are they doing this on purpose? And it's not because of the intellectual disability. It is far more profound than that, because the group home folks are telling me this. This is not normal. Things are getting worse. So in addition to him consistently coming, like I probably told you on the first night when we talked about this guy, I was talking about him from the point of view of stigma, and that the emergency room was really busy that day. So they just kind of pushed him onto us. That was the other guy. This one was my own staff, our own mental health people. Were saying it was a protective factor to have Down syndrome. This guy was faking it because he wanted attention. He wanted to come to the hospital for the pizza. I actually heard somebody say that, which was absolutely apparent. With all of these things going on, nobody was taking him seriously except for me. And again, he was really not doing well with all of these mental status things. Nothing was changing week to week when he would come back, his report, all of that stuff, except for the fact that he started to try to cut his own wrist, and that his motor activity was slowing down. His affect was getting worse. His thought process was starting to get a little paranoid. When somebody becomes acutely depressed for a long time, things get different. They get very off from what the person would normally be like. A person can get very paranoid. You can have hallucinations from acute depression if it goes on long enough. So all of those things together was why I was like, okay, this guy needs to be seen for more than a few hours. And that's what we did. But the concept of diagnostic overshadowing was there because our psychiatry team didn't think that he needed it, which was absolutely wrong. I'm gonna get you one more case study, and then I'll stop talking. I'll make it quick. I know we're up on the hour. This is a good one. If you're squeamish, maybe you don't want to hear this. Long story short, we had same situation in the emergency room. Sometimes people would come right into our area. They're supposed to get triaged in the medical area first, seen by a physician, seen by a nurse, get their vitals done, all of that. We get a phone call that there is a patient literally coming in hot, already being put into restraints in the ambulance. This person, we don't know anything about this other than the person is supposedly psychotic and completely out of control. What happened? We don't know. This guy is, let me go back. He was in his 30s, if I remember from the previous slide, which is really old to become psychotic for the first time in your life. Typically, men will become, if you're going to have schizophrenia or something like that, it's going to come out early 20s or younger. Women, it's a little bit older. But into the late 30s, doesn't happen. It's just, that's something that we immediately noticed, like, this doesn't sound right. Shouldn't be psychotic for the first time. Nonetheless, comes in from his group home. He's living in a group home because he has I believe it was profound autism spectrum disorder with severe IDD. This is a guy who cannot verbalize his needs. He is needs assistance with every daily living activity that he has. So this guy is hands on a good day. We didn't know any of this. We just know that he's acting psychotic out of nowhere and don't know what's going on. There's some stuff here in the mental status exam, but realistically, what happened? I'm walking in for my shift that day as this is all starting off. And here comes the squeamish part if you don't want to hear it. And the person, the patient, was standing in the middle of the unit with his back to his door, and he was taking his own head and slamming it into the wall, the door, and the window because we couldn't figure out what he wanted, and he was getting so angry and so upset, and we didn't know what he was doing. And then he started ripping out his own teeth. This was one of the most horrific things I've ever witnessed in my life, to the point where he was given intramuscular antipsychotic medication, among other things. Again, it's not like what you see on television or in movies. That medication takes 15 to 20 minutes to work its way into the person's brain and their circulatory system. So this person was thrashing around in restraints, which is traumatic in and of itself. Long story short, we all were wrong. There was nothing psychotic with him at all. He had tooth decay, and that's why he was doing what he was doing. He kept hitting himself because he was trying to show us and tell us that he was in pain, and nobody could figure out any of that. That story is there as a teaching device. God forbid that ever happens. Like you're calling whoever you need to get yourselves help and stuff like that. That's not something that's going to happen. But I tell you, such a really powerful story. I rushed it a little bit because we're at the end of the hour here, but I tell you that because you're going to remember that happened. And if you're looking at somebody that's in front of you, you might think there's other things to look into about that person, why they might be acting differently, why they might be acting like there's a need that you can't figure out. Jumping to the conclusion that the person's psychotic for the first time when they're 37 years old is a big one. Would we have ever figured that out, easily? Probably not, because the person was unconscious and then they could start looking at the person. But there were a lot of things missed by their staff and caregivers for that person to then arrive to us in that condition. This was probably going on for weeks, to the point where this person was probably potentially even getting psychotic just because of the pain that they were in, not because they had a mental health disorder. So I'm going to stop there and do my usual offer if anyone has any questions. And then there's a lot more on these slides, which I will go back to and finish up when we have our final session with one another, and do a lot more about mental health in general as well. Anyone have any questions, comments, or anything that they want to share? Okay. Well, in that case, I am going to have a good night, everybody. I'm going to make sure that this is available to you. I know that they haven't been sent out yet. That's on me. That's not on your MRC. I had to get special permission for this to be translated into a PDF file so that I can send it out to everybody. But it will come. It is coming, I promise. Yeah. So with that, thank you. I'll stick around for another minute or two if anyone has any questions. And if not, I hope to see you guys again soon.
Thanks, Jason.
No
Thank
problem.
you.
Everybody's still here. Nope, there we go. Okay. You're welcome. Thank you. Have a good night, everybody.